Okay, guys, welcome back. So, in this unit, we'll be discussing the basic format of the interventions that you might see done in a pulmonary rehab setting. So, the basic format of a pulmonary rehab program, again, the plan of care typically range between 4 to 12 weeks. There are some studies that looked at 23-week programs. Again, we're still trying to find the optimal duration and frequency, but this typically seems to work 4 to 12 weeks, 2 to 3 sessions per week, and you typically reassess patients at the end of 6 weeks. Okay, so that's where typically we see our reassessments. Endurance training you typically see is the large bulwark of the program. We'll go over what you might do maybe in a patient with more severe limitations. We may do more we may favor more other modes, but typically endurance training is going to be the bulk of what you do. You'll see some resistance training, some balance training, especially patients who have balance impairments, maybe some respiratory muscle training if they have respiratory muscle weakness. And realistically, our goal is to always adjust the work intensity so that patients can exercise. We can, facilitate, overload principles and make improvements, like in those sound principles from strength and conditioning and exercise physiology. But we can make sure it's tolerable for the patient so that, again, we want to work them out hard. Like we want this to be vigorous, right? We're not vigorous. We want this to be the stimulus to be sufficient to result in gains, but we don't want them to get into an episode where they are undergoing severe coughing spell or dyspnea, where they are taking a 5-10 minute break to recover. Like we want them, so we need to titrate dosages of intensity to allow patients to exercise to make improvements, but not so much that we're working them up and creating symptoms. Again, that may also feed into impaired adherence too. People get super dyspneic every time they come to see you, and they're not really making much improvements. They're probably not going to be too compliant. They're not going to want to keep going back to something like that, right? So we might want to look at using intervals between exercise, those rest periods as well. We talked about that. And then maybe adjusting oxygen supplementation. Now that's going to depend on your state in your institution. Some places have an umbrella protocol where PTs or anyone in pulmonary therapy rehab is able to adjust the oxygen just to meet a set pulse oximetry. Some places it might be a little bit restrictive. Where we practiced when I was an outpatient in the VA in Madison, Wisconsin, we had an umbrella protocol, right? So we were like, just whatever we need to do to keep oxygen saturation above 90. So every state's a little bit different. Every system is a little bit different too. And remember, oxygen is a drug. So treat it like one. So aerobic training, again, the majority of the studies, that, again, it's where we kind of develop our guidelines from, is from research. The majority of the studies have looked at aerobic training interventions during pulmonary rehab. That makes sense. If we understand, it's a lot easier to conduct a research study doing aerobic training because you can monitor and look at acute effects. But it makes sense if people have issues with endurance, we want to train endurance, right? So the way to do that is aerobic training. Typically, it's going to be using moderate intensities, 40 to 60% of max, or we might use a talk test, whereas we work them up to a point where they can maybe still get out they can get out some words. It's a little bit difficult for them to a little bit difficult for them to talk, but they can still, carry on a conversation. We don't probably want to work them up to a point where they don't have any air to spare, right? Where they can't get barely a word out, but it should be a little difficult for them. And that's, that moderate intensity we're looking at, right? Anything below that would be falling under that light intensity, which has its purposes, but typically most of the evidence looks at moderate intensity. Another way to do it, if you don't have access to a cardiopulmonary exercise test to get a VO2 max, you can use a submax test and estimate it. Or there's been some research looked at using 80% of the average gait speed during a 6-minute walk test, right? Because you'll get what their self-selected highest pace during that test to a certain degree. If we use 80% of that, it kind of falls within that range we need. We want to train people at. So you can look at average walking speed during the 6-minute walk test, and then prescribe the walking speed on a treadmill according to that. Durations typically last 30 minutes continuously, or 10-minute intervals, and you'll ramp it up just like you would in any traditional program. The new step, which I have here, is really popularly used in pulmonary rehab, a little bit easier on patients. Their back can be supported. They can use their arms and their legs. That's a great way to train patients in pulmonary rehab. So the new step, you'll see that used very, very often. Big fan of it. Then strength training, right? So again, we see significant reductions in strength. And if you have, muscle weakness, atrophy, it's associated with higher utilization and poor prognosis. We've seen a lot of associations with that. So our recommendations are to use progressive strength training for patients with COPD, improve muscle strength. And again, we know if they have problems with ADLs, the best way to probably improve ADL function is to improve strength. Most ADLs are strength-based activities. So again, goes back to those sound principles from strength conditioning, right? Task specific. If we want to improve ADLs, we got to train using the energy systems, the movement systems that we use when we're performing ADLs, which are strength-based movements. So if we want to improve someone's ability maybe to get out of a chair, let's practice that. Let's do some sit-to-stand squats. Let's do some bodyweight squats, or you can do some leg press. Build up those muscles so they can perform those ADLs. It may actually be better tolerated. So someone who's got very severe pulmonary limitations, again, we talked about the ventilatory changes that occur during exercise, especially continuous aerobic exercise. We don't see the same ventilatory demands occurring during resistance training, right? It's usually in shorter intervals. You don't see those ventilatory changes occur with strength training. So in patients with severe respiratory disease, I may use more of a strength-based protocol because I'll still probably make improvements in their ability to function. I'll still improve muscle mass, improve muscle strength, maybe improve balance a little bit as well, just from improving strength. It also gives them something that they can do and be successful performing without getting really significant symptoms. I also may use this as a starting point. So like I mentioned, really get the benefits from aerobic work. We got to be at, durations above like 20, 30 minutes. Sometimes I have patients who can barely complete a 6-minute walk test. They take 3 rest breaks. Am I going to be able to get them to a walking intensity or even on a new step, which is a little bit easier than walking, for that long? Probably not. So maybe I want to start with something that's not going to have that high of a ventilatory demand, like strength training, and improve the quality of those muscles. I mean, often we even see carryover to aerobic work, even using a strength-based protocol, especially in deconditioned patients. So strength training, big fan of it, definitely has a place in pulmonary rehab for many, many, many reasons. Typical programs, again, we see in the literature 6 to 26 weeks. Again, you'll just fit it just like you would, the 4 to 12 weeks depending on your program. You'll see 5 to 12 exercises used, usually a combination of arm, trunk, and leg exercises. You want to have higher rep volumes for patients, but the evidence has utilized, or in previous studies, training intensities or training loads ranging between 32 to 90% of 1 rep max. Probably still want to do your typical, 60 to 80% 1 rep max, your typical ranges for improving strength and hypertrophy in these patients. So again, you're going to tailor this to your patient's unique needs and abilities, but just to let you know that strength training typically has a place in pulmonary rehab. Probably going to want to be working at higher rep volumes, which means you'll probably be at lower intensities in terms of 1 rep max for these patients. Now, the other question is combined. Does combined exercise training have a role doing a bit of aerobic and strength? Well, as we talked about at the very beginning, yeah, absolutely does. You're going to do a combination of both during a session, right? The evidence actually is pretty strong, very strong support for the combination of both aerobic and strength-based protocols. Now, interval training, I think, is, especially for patients with COPD, again, if patients with COPD, especially who have those dynamic hyperinflation, the longer they go, right, because of their expiratory limitation, they keep trapping more air because breathing speeds up, do all of the peripheral inputs to the body, which cause breathing to go faster. So we find that by using intervals, right, we can actually allow their total duration of exercise to be longer, because while they're not going for 20, 30 minutes continuously, if we break things up into small little chunks, 2 minutes at a high intensity followed by a minute rest, 2 minutes at a high intensity, right? It may decrease their symptoms, right? Because they're not going for as long. So we might be able to work them out a little bit harder, but break things up into shorter intervals and giving them that active recovery or passive recovery. So again, you can use a high intensity interval approach. You can use a low intensity interval approach. Either way, breaking things up into those shorter bursts can be again, it's shown that in severe COPD, a study by Courtenau that's published in 2010 showed that in severe COPD you can almost triple the total exercise duration with lower and more stable metabolic and ventral responses compared to continuous exercise. And here's a graph from that paper showing again this the black dots are individuals who were in doing a continuous program, and the clear dots are individuals doing an interval program, right? So we got them to exercise, again, almost 3 times as long. So those doing continuous work, right, eventually got to a point where they had to stop, and those doing interval work were able to continue. As you can see, like we mentioned, that dynamic hyperinflation. So MVV, again, is the total amount of air you can move out of your lungs. These individuals doing continuous work eventually got pretty close to that point, whereas those doing interval work, right, they were able to stay below that, right? And that's probably why they were able to continue to exercise. So the continuous people got pretty close to their ventilatory limit within 10 minutes of continuous work, while those doing interval work, right, were able to continue on even for 30 minutes, despite it was broken up. And if you look at consumption of VO2, like those doing continuous work got pretty close to their VO2 peak, so that's during a cardiopulmonary exercise test, whereas those doing that interval work were able to kind of stay a little bit below their peak as they continued to exercise. And if you look at ventilatory responses, so dyspnea got a lot higher in patients doing continuous work, went from 0 to 10 minutes, they were at 5, whereas individuals with doing interval work, on the average were 2, 3, and then at 30 minutes they were at 5. Leg fatigue as well, same thing, like much lower in patients doing interval work, and looking at blood lactate, right? Despite doing an interval approach, they were much lower. Again, if you have that ventilatory deficit, doing continuous work just may not be something in the cards for you. Again, even thinking maybe some of the metabolic changes that happen in the muscles, like they don't maybe not have a high amount of mitochondria. We might see fiber type changes. So maybe working with what they've got, right? Realizing there may be fiber type changes in the muscle that may not be super conducive to continuous aerobic work. Doing bursts of work, doing those intervals may be a little bit better to work with what they've got. And again, it's an example here of a basic progression that you can utilize for interval training here. And that's something we can even stack those breathing techniques. We can even do some pursed lip breathing during rest periods, right? We can teach them how to maybe do these things in recovery that they could translate maybe at home. So hey, you can do a little burst of activity, take a rest break, do some pursed lip breathing, control their symptoms, right? So it's something they can do at home during ADLs, like stair climbing, walking up hills, right? Constraining activity to shorter bursts, so they don't get super symptomatic. They don't get their legs super cramped and fatigued. They don't get into these breathing and dyspneic kind of spells. Work things in a little bit more manageable situation. So interval training, big fan of it for patients with pulmonary issues enrolled in a pulmonary rehab program. Big fan of it. So balance training. Again, patients with COPD exhibit deficiencies in functional balance. We think it's associated with it has been shown to be associated with pulmonary function. They also have a high susceptibility to falls, and also associated with worsening dyspnea. So the research is pretty strong in supporting the use of balance training for pulmonary rehab for improving balance performance, muscle strength, physical function, and it's overall quality of life. Like if you're a little bit more stable, it's going to be a little bit easier for you to get around and kind of do things throughout your day. We'll get into some more specifics of why this probably happens. One of the big reasons is, in particular, outside of just the changes to the muscle and the nerve or your ability to, contract and use your muscles because you don't use them too often. You may see changes in center of pressure, right? Especially if you have, super significant kyphoscoliosis, which may, impair your ability to right balance to different disturbances. But again, which is kind of what we're seeing here. Like it's pretty strongly associated with patients, with different severities or different measures with different pulmonary measures. So timed up and go, community balance and mobility scales, like strongly related to FVC, peak expiratory flow, and FEV1. So typically, the more severe condition you have in terms of COPD, we often see pretty significant balance impairments as well. That's why balance training is a big component of the pulmonary rehab, and it's why you should consider assessing balance in a patient with respiratory conditions. So inspiratory muscle training, we'll get into this later on. I would consider if patients have inspiratory weakness, we'll go over what that means in the back end of this lecture. This is great for improving the strength, efficiency of the diaphragm. The great thing about inspiratory muscle training, they can do it seated. They can do it very short durations. Typically, we're looking at 10 to 15 total minutes per day, which usually involves like 30 breaths done over 5 minutes against a resistance. We'll go over what that entails. We can see significant improvements in inspiratory muscle strength, which we mentioned we need to fully recruit the lungs as well as to clear the lungs, endurance, and exercise capacity. If the muscles in your breathing muscles are a bit more efficient, we can often spare blood flow to your peripheral legs. Quite often in patients with COPD and other pulmonary conditions, the diaphragm's overactive because it's weak, and it steals a lot more blood flow because then your body's always going to preferentially prefer you to breathe than to be moving. So if we can make those muscles stronger, more efficient, we can spare blood flow, spare energy to our peripheral muscles, which will then allow us to exercise a little bit better. We'll go over some of the other unique things involving the respiratory muscle metabolite reflex, which is also involved in patients with with inspiratory muscle weakness, and how we can improve that with IMT. Probably the biggest thing that we see with IMT is improvements in dyspnea. So if patients have dyspnea, probably want to assess inspiratory muscle performance, because dyspnea really is often due to an imbalance between the demands of breathing and your ability to produce force of breathing, right? So we know if the respiratory muscles are weak, they may have dyspnea. So if someone reports shortness of breath, who's stable, right, we want to assess how strong are your breathing muscles, and we'll go over how to do that near the back end of this lecture. And it may or may not improve PFTs. The evidence on that's kind of inconsistent, whether or not, and that's not super relevant either, whether the PFTs improve with IMT because of the improvements in dyspnea, quality of life, and exercise capacity. That's really what your goal is for inspiratory muscle training. And then patient education, right? So again, just getting people more aware of their condition. For self-management, adherence to healthy living, right? It's a big thing. We can spend hours in the clinic each day. Patients are going to spend more time on their own. We need to be able to equip them with resources and knowledge that they can manage these things without having to come in for a clinic visit, or at worst, a hospital admission because they ate something wrong, or they're around people who are smoking, or they were smoking themselves, right? So self-management's great. It's important to note that education alone has no independent benefit. We need to be including an active treatment component too as well, whether it's an exercise training routine or stress management, stuff like, or symptom management of some kind, right? So education, huge part. It's not the only part, right? It should never be the only part of pulmonary rehab, right? Exercise is really the big important thing there. Flexibility training. Really no clinical trials demonstrating its effectiveness. It might improve vital capacity. If we improve the ability for someone to, expand their chest and move air in and out. I use it here and there if it's indicated someone has a mobility deficit. I'm gonna probably do things to improve mobility in their musculoskeletal system. Is it the bell cow of a pulmonary rehab program? Not really. But again, if someone has a limitation in flexibility, in soft tissue mobility, yeah, then maybe I'll look at it. But not the top priority intervention for my patients. Tai Chi, great intervention for really for anybody, but we also find this might be used for patients with COPD. One, because the movements are fluid, which we talked about how that balance may be an issue. It's a great way for them to kind of practice control. It also includes meditation, which can help reduce anxiety, can relax and calm people. It also includes controlled breathing, giving people techniques that they can follow. They control their breathlessness if they encounter it, right? Like being able to give people tools or cues they can give themselves to control their symptoms that they ensue. So Tai Chi has been shown to be effective in improving exercise capacity because it's an active component. It's a martial art. Balance, right, because of the controlled movements, and health-related quality of life because of the stress management, the breathing techniques we teach people to help control their symptoms, and anxiety potentially if they get symptoms. So here's an example that I actually do Tai Chi pretty often. There's videos for this, so this might be a great we call cardiopulmonary potpourri, something that people can do as an adjunct to what they do in a pulmonary rehab program. Or maybe something for a maintenance program for patients. I think this is a great maintenance program, something they can do at home or maybe in a group class with people as well. So if you're designing a pulmonary rehab program, it might not be a bad idea to have, maybe a couple times a week, a Tai Chi course so that people can kind of come to their clinic and do it in a group. And there's just some examples. I'm not going to go over these from the ACSM, from the American Thoracic Society, and AACPR. AACVPR is the American Association of Cardiovascular and Pulmonary Rehabilitation. They're a great organization for looking at very practical tools for implementing cardiac and pulmonary rehab. The ACS, American Thoracic Society, and ERS, European Respiratory Society, are the professional bodies for really anything pulmonary or respiratory. They're fantastic organizations. And the ACSM, the American College of Sports Medicine, has guidelines on all kinds of different conditions. So here's some stuff that people can kind of consider to follow in a typical program. Just to give you some pragmatic stuff you can consider implementing. All right, so the next part we'll get into some unique things that may be going on in terms of balance and respiratory muscle performance in patients with COPD. So again, this was a summary of all the things we can do to improve patients, undergoing or going through a cardiac and pulmonary rehab program. The next we'll get into specifics on looking at why balance beyond just some of the changes maybe to muscle function or peripheral muscle function and musculoskeletal issues. We'll get to look at some maybe unique things that occur in patients with COPD and maybe some other conditions as well. So, all right, thank you.